same spot, and then I'm just going to get my measurement there. Come back up here again. Okay, one more time, rotate to the right as far as you can go. I got to get down here and take a look. Yeah, so on this goniometer, it reads 80 degrees, okay? 80 degrees of rotation, right? And so again, you know, we've talked about numbers. Those numbers that we gave you for rotation, remember, was for the standard goniometer, right? And so this inclinometer technique that you're using, the single inclinometer technique, these motions are consistent for the patient, right? So you have to continue to use this technique, right, as a range of motion measure if that's what you want to do. Can't interchange the two. Rotate toward the side as far as you can go. Okay, good. 80 degrees. Okay, and that's reasonable, right? It's reasonable. You're talking about 90 degrees here, right? And he has pretty good range there, okay? So any questions on this particular technique, right? So we want to make sure they get all the way down range. We're assessing for symptoms, okay? Let's go ahead and do that. Thank you. What's up? Say again?
Like bring this down so it's level.
Yeah, I would do that. Yeah, yeah. Make sure it's level. Single. Just one. Yep, but that's for the standard goniometer. Inclinometer, we don't have necessarily normative data for it. Okay, that's what I'm saying. So if you do this technique, that's correct. That's correct. And you should document it if you're, you know, that's good academic practice. But at the same time, it's good clinical practice too. For tonight. Oh yeah, yeah. Well, what happened over there today? We didn't get. We'll have the camera for this one now.
Oh, you do have stuff sharing. Okay.
I tried watching it. I didn't like it this morning. I was like, I gotta turn this off. I can't. I got to go 35 minutes.
I talked to Terry too. Like, I was like, I don't know. Yeah, it was like, do you want me to pause this? I'm like, I'm gonna go take a shot. I was like, no, I'm good.
Yeah, I watched it for like 10 minutes this morning. And they were talking about COVID and turn it off. I'm like, these are the two best people you get. These two.
You're finishing up on the other side. How we doing on the other side there? How we doing on the other side? Am I muted? Oh, I am. How about now? How we doing on the other side? Okay. All right. Any problems with that technique? Rotational range of motion. So range of motion is really going to be important. If we think back to, that we'll start talking about on Monday with respect to treatment. If we think back to that clinical treatment algorithm that we spoke about, range of motion limitations are going to be a key component in how we classify our patients. If we see range of motion loss, we have to figure out how does that loss translate into a functional or an activity limitation. And if we get that motion back, right, at least hypothetically, right, those activity limitations and functional limitations should diminish, right? So if we see range of motion loss, we need to get that back. Okay, we need to get that back. And we're going to use manual techniques for that. We can use range of motion activities for that. We used to not be able to say stretching around here, but you can stretch someone, right? Tight upper traps, tight scalenes, right? Tight sternocleidomastoid musculature. Stuff happens over time where muscles adaptively shorten. So sometimes we have to stretch those muscles, okay, that are limiting that movement, okay? So that's range of motion. Very important. You're going to see this checked on all of your patients in the clinic for clinical exposure. People are looking at range of motion all the time, making clinical decisions based upon that. Are folks always using a goniometer? Maybe not, right? You may see your clinical preceptors for clinical exposure saying there's a 50% motion loss, and I'm just eyeballing the range, right? And that's fair, right? But we want you to make sure you know how to use the goniometer as well, so you can be a little more precise than just making a percent loss. We're going to move into muscle performance and strength now. Muscle performance and strength. If you have the handout, I know some of you do have the lab handout. We're working with Clay Case to get him in to give you guys a solid hour of lab on these concepts of repeated movements. Repeated movements and how they're going to fit with our range of motion assessment. The range of motion assessment we've done here today, this is just single range, single movement, right? We're looking at how far someone can move and if there's pain associated with it and trying to get a measurement on that. But those repeated movements are going to be key. Again, that's part of that clinical algorithm we spoke about, that centralization group. And what patients would you automatically, when you see them walk in, you look at their body chart, what patients are you already going to start thinking about? We want to think about repeated movements to try and centralize. How are they going to present? What would their body chart look like? Potentially referred, but where would that pain be located? You could just have localized neck pain. Okay, you have localized neck pain. But that centralization, you know, when you read about it, it's more for patients who are going to have distal symptoms, right? So that could be referred. That could be referred from the cervical spine for a variety of different reasons, but we're talking about symptoms into the extremity, right, that we want to move proximal, right? So that's that's the type of patient that automatically you start to think about, I really want to exhaust those repeated movements with. And we'll talk more about that, okay? But muscle strength is going to be important as well. Muscle strength is going to be important. We know that for the cervical spine, specifically, especially the deep neck flexors, that's definitely a muscle group that we're going to want to address. But there's other areas of the neck that could be weak as well that you're going to want to address as well. And so the manual muscle testing is going to be important for that. And so I want to talk first about a couple different movements. And I think you've already started to talk about this with Dr. Ford, the movements of the upper cervical spine, the atlanto-occipital joint, right? What movements occur there, right? Well, for flexion extension, it's this nodding movement, okay? This nodding movement. So we can nod posteriorly, right? Look up toward the ceiling, that's extension, or we can nod anteriorly, right? That's that little bit of a nod. And so if you look at the picture I have in the book on page, Dr. Bogalski's working that there. Page 25 in the book, we call that capital flexion extension, right? So that's the atlanto-occipital joint, right? There's probably a little bit of side bending there too, but we're talking about flexion extension. So everybody just try that. Just this flexion extension. You're not moving your neck, right? It's flexion extension, right, of the atlanto-occipital joint, right? So flexion here, extension here, right? Flexion here, extension here. Those are movements that are going to be extremely important. So once again, we start thinking about these folks who potentially have cervicogenic headaches. This is a joint that we're going to want to assess because sometimes these motions are limited, right? And then I saw some of you doing rotation when I asked what movement occurs at the atlanto-occipital joint. Where does the majority of, well, about half of rotation, where does that occur? AA joint, that's right. So about half of the rotation occurs there. So again, we're going to have to teach you guys how to assess rotation at the atlantoaxial joint because that's an important component, right? That's an important component. Again, upper cervical spine, from occiput down to about C2, C3, we're thinking about cervicogenic type headaches and manual techniques we can use to try and improve some of those movements. And you can use other things as well. But those are going to be key. And so everybody should have this movement down here, this nodding movement, right, into flexion, this nodding movement back into extension. That's capital flexion, capital extension. And the motions that you just did with your goniometrics, the last class, are going to be these cervical flexion extension movements down here at the bottom, right? These gross movements of all those cervical vertebrae, okay? Cervical flexion extension, right? And you may get some contribution of the upper cervical spine into that, but in that case, we're really looking at probably C3 down, right? Those movements down there at the bottom. And we're gonna assess strength for both, okay? So for these particular techniques, certainly for extension, the head is off the table. So you guys need to listen now. The head's off the table to test these patients. So anytime you move a patient off the table, for whatever reason, safety is absolutely paramount, right? And that's the one thing about this program is we do not play around with issues pertaining to patient safety, right? So if a patient comes off the table, right, you have to have a hand under that head at all times. Is that fair? You can't go walking away, leaving the head hanging off the table while you're adjusting tables, go grabbing a cup of coffee. So I'm not going to tolerate any of that, okay? I'm not going to tolerate that. Heads come off a table, you need to make sure that you're in an appropriate position. Patient comes off, they need to know exactly what they're doing. Because we're going to have to put our hands on the face, specifically, we're in this T-zone, right? You guys know what the T-zone is, right? Cross the eyes down, right? That's the area that you're not supposed to touch. Well, now we're touching people, okay, here today. So we have gloves, okay? We have gloves. But it's absolutely paramount, and you can certainly use the gloves, but you can also use hand sanitizer before and after the technique. All right, so let's go through that again. You can use gloves, okay, which I'm going to use when I test the subjects here, up here for demo purposes. And then the gloves come off when you're done. You still use hand sanitizer before and after, right? But you can also use hand sanitizer before, right? Do the technique and then hand sanitizer immediately after. We good with that? So I'm not, and like I said last time, and I mentioned this to Dr. Bogalski when I spoke to her last night, I didn't really go around, and I don't think we're doing this where we're checking to see, are you guys using hand sanitizer when you're up into the face, right? But you probably should, right? Beforehand and after. So if you watch me treat a patient, not just with COVID, right? I'm gonna do my history. I'm gonna wash my hands before I bring the person back. I'm gonna do my history. I'm going right there, I'm washing my hands, right? And then I'm gonna come back, and likely every time I'm kind of touching the patient, I used to have, hand sanitizer right there. You're just kind of doing it. And so immediately when I'm done with my exam, I go wash my hands again. I'm gonna start talking to the patient. And so, before I came to Buffalo, I was extremely hyperactive. I couldn't go to potlucks, buffets, handshake stuff. I didn't like any of that stuff. And then I don't know what happened. I came to Damon. Who cares? Holding hands with my lady friend, shaking hands, giving hugs, kisses to anybody. Buffets didn't matter anymore. But now I'm back, I think. But I'm not probably as concerned as I probably should be. And all of us kind of fall back into these habits. And so let's really stay on top of that, get into that habit, because that's what you're going to expect clinically, right? That's what's going to be expected of you clinically, okay? Any questions on that? All right. So let's go ahead. And if I don't have a student here yet. I know they're coming. The students, I believe, are coming. We have TAs for the class. And so let me just talk about this capital extension for a moment here. It's important to know what the musculature is related to this. And so the two biggies that I want you to be concerned with, because you guys are going to be up, are you guys, and I just haven't had a chance to talk to Dr. Steen, but are you guys into the occipital region yet, dissecting? So you're into that. Below the occipital region in the C-spine? Good. And you guys dissect out the upper cervical spine too? Yes. Little louder. Perfect. And so you're going to see, right, some of these muscles here. And so the big ones that we want to think about here are going to be the splenius capitis, right, and the rectus capitis, right? The rectus capitis, attaches to the spinous process. Splenius capitis is a little lateral, right, off the occiput. And those are muscles that are going to be important. Is everything okay? Yeah. Those are muscles that are going to be important because for grade 1s and 2s, we have to palpate, right? So grade 1 and 2, have we talked about muscle testing grades? Probably not. Yeah, we have, good. So for grades 3, 4, and 5, the patient's going to be prone, head off the table. Okay, this is why we're going to be, we're going to be very, very cautious with this position because the head's off the table now, so there's a safety issue there, right? But when we move the patient into a grade of 1 or 2, the patient's now going to be supine, and we're palpating, right? We're palpating. And we're palpating specifically those splenius capitis muscles laterally, and you can palpate the rectus muscles because they attach, you can palpate the spinous process, the upper cervical spine. If you just move laterally, right, you're on rectus capitis, right? So those are the muscles we're going to palpate. Okay, so let's go ahead and have somebody, let's have someone come up. If someone wouldn't mind coming up. Anybody wouldn't mind coming up. Sweet Jesus, man. I love it. Thanks, man. That's all right. That's okay. That's okay. How things going? All right. So what we're going to do today is we're going to start with capital extension. Okay, capital extension. Let me just push this down a bit so you guys can see, right? Capital extension. And the movement that's going to happen here, just go ahead and let me talk to you first. So the movement that's going to happen here is we're just looking at this movement of this little bit of a backward nod. So let me see you do that. Just that capital extension right there. That's all we're looking for. And my command to him is going to be, all I really want you to do is raise your chin up toward the ceiling, right? Raise your chin up toward the ceiling, right? And when I lie him down prone, my command is going to be raise your chin up toward the ceiling and try and look at the wall. Okay, so that's what we're looking for. Chest stays on the table. right? Chest stays on the table. It usually isn't a problem for this because we're just looking at just lifting that chin, right? And we're asking him to look up at the wall. That's what we're gonna ask him to do. So I'm gonna lie you down with your head off the table, okay? Hang on a second. So watch the hand positioning for this though, because when we're resisting this movement, we're resisting capital extension. And so if he's gonna lie down with his head off the table, I'm gonna support his chin, right, with my left hand. My right hand is gonna be cupped over his occiput, right? And this forearm's likely gonna be in line with the thoracic spine because I'm resisting this right here, okay? And it doesn't have to take a lot of force to resist this, okay? What's a grade 3? Against gravity. How much motion do we expect to see with this? How much extension do we have total? Anybody? We're not thinking about cervical spine yet. 25 degrees for the upper cervical spine extension. Is that the total that we talked about? What's normal range for cervical extension? How much? 45 degrees. So 25 of this we're going to expect from the upper cervical spine. That's what we're going to get. All right, we ready? And so I'm going to raise the table up because Damon's been good to me. And as I mentioned, when you go out looking for jobs, if you see clinics with all tables like that, I don't know what to tell you. You see nice high-low tables like this, now I'm happy, right? And so the first thing we're going to do is we're going to come off the table. My hand is going to stay right at the chin the whole time. My resisting force, again, is going to be here with this hand right at the occiput, right at the occiput. And my command is going to be, for this grade 3 first, okay, I'm still holding my hand underneath here. Chest is going to stay on the table the entire time. All I want you to do is do that little backward nod and look up toward the wall for me. Perfect. And come on back down. There's a 3. Okay, all I did was just have very, very light touch contact on the chin here. Okay, now for a 4, I'm going to apply some resistance through that. Okay, and I want you to go ahead and give me your best effort. Good. So there's my 4. Come on back down. Now for a 5, right, I'm going to provide that moderate resistance again, but then at the end, now we're adding additional resistance, so we're going to hold that for a slow count of 5 to get to be a 5. Okay. So go ahead and come on up again for me, and you're going to hold at the top. 1 1,000, 2 1,000, 3 1,000, 4 1,000, 5. And my resisting force, slide back on the table, is this, right? So I'm doing this, right? Not just forcing him, but I'm trying to get that force going. I'm trying to create that forward nod, okay? That's grade 3s, 4s, and 5. For a grade 1 and a grade 2, like if he can't go through full range, right, or he can't do the movement, right, I'm going to go ahead and lie him on his back. Lie him on his back. And my hand, my fingers are going to be right at the base of the occiput. I'm flipping the page to page 24 there, Dr. Bogalski. My fingers are going to be right at the base of the occiput again, palpating for the recti and the splenius muscles. Okay, so I'm going to be here, right there at the base of the skull. And what I'm going to ask him to do is look back up toward me, right? Look back up toward me. Perfect. Come on back down. That's that little motion right there. And if he can do that motion, right, any motion, there's a 2. Try it again for me. Perfect, perfect. And I'm going to keep my fingers right underneath here, try it again, and come on back down, all right? A 1 would be, they're really trying hard, no movement's occurring, but I can palpate muscle activity. Are you going to see that a lot next summer with your patients? Not sure what that is, but are you going to see that a lot next summer with your patients where they cannot move into capital extension? Probably not. Probably not. Now, summer of 2022, might you? Doing a neuro rotation? Possibly. Right? Try one more time. Good. When somebody come up here, just put your fingers, have a seat here. Put your fingers at the occiput, base of the occiput there. And go ahead and do that same thing again. Can you feel those muscles pop in your fingers? You can feel those muscles easily, right? Those are the deep capital extensors. Okay, you can palpate those. Perfect. Questions on that? All right, let's give it a go. Thank you, sir.
So folks, if you want gloves, you're welcome to take some from the back. There's hand sanitizer on the walls if you didn't bring your own.
Alright, my name's Amanda. I've received a for today. Assess for cervical
or this, or the classroom, right?
Yeah. Yeah, they have to vacate. I mean, technically. Yeah. That'll influence you because you're teaching over there, aren't you?
Yeah, the only thing is the next 3 weeks are hybrid.
Okay. Okay.
So I'll be online the next 3, so I
Yep.
gotta focus on that end.
Yep. Yep. All righty. How we doing with that? We doing okay with that? Right. Your book is great because on page 24 they give these little tables and boxes of helpful hints. And so in this particular case here, they're talking about that the head, the book talks about, it's about 1/7 of your body weight, believe it or not. So it's a heavy object, the head. That head coming off the table, especially in patients who may have pain, that pain inhibition could be a factor in them being weak. And so we want to ensure again that we're safe or we're bringing these patients off the table. I didn't mention it last time, but some of you had the patients off a little bit too far. You only need to bring them off likely to the point where their shoulders, right, are just to the top of the plinth, right? So if they're farther off than that, there really isn't a need for that. It's just the head coming off the table, okay? And so we did capital extension there, and I would ask you guys to work on that still, because some of you, I think, are still struggling a little bit what that movement is. It's just this little nod forward for flexion, little nod back for extension, right? About 25 degrees of motion there, not a lot, just that little nodding type motion. And again, cervicogenic headaches, that's a joint that we're going to assess, and this is a movement we may give patients to work on, right? They might be limited in some of that. And so let's move into capital extension, or cervical extension rather. So we're looking at cervical extension now. And for cervical extension, you guys probably dissected these out, I'm sure, right? Iliocostalis, longissimus, and semispinalis are going to be the prime movers for this here. Okay, and we can palpate those. Book does a nice job of giving you a nice muscle chart with that. But in this particular case here, right, we're going to have the patient again off the table, right? And note how the shoulders are right up to the edge of the plinth, right? And that's probably where we need to be. For this particular technique, I'm going to switch my hand placement now, okay? And so I'm going to be on the side of the patient, and now I'm resisting that cervical extension motion, right? So if I have Chris in that exact same position I was before, my right hand will now be under his chin. Before it was my left hand to resist that capital extension. But now my right hand will be under his chin if I'm on the exact same side, and now I'm resisting cervical extension with my left hand, okay? And so the command here is going to be, we want you looking straight up, right? Looking straight up, right? But we want you to keep your eyes on the floor, right? So move your head up and back. We want you to keep your eyes on the floor. Why eyes on the floor? That really minimizes a lot of this capital extension, right? We're looking at cervical extension at this particular point. So eyes on the floor, we want them to look straight up, right? As far up as they can go. In this particular case, they talk about range of being about 30 degrees. 30 degrees in the, probably from C2 down to about C7. And you get that little bit of a 25-degree motion at the atlanto-occipital joint. That's going to get you that 45, 55 degrees of cervical extension. Okay. All right. Okay. For grades 3, 4, and 5, the patient will be prone. For grades 1 and 2, we're going to flip the patient to the supine position there, and we're going to palpate, and we're going to move our hands distal now to the occiput, right? For capital extension palpation, you were just off the base of the occiput, right? Just off the base of the occiput. Here we're going to move our fingers down to palpate, right, the musculature of the cervical spine. The other point here is that if the patient has, and this is fair for practicals as well, if the patient has trunk weakness, we're going to want them to stabilize, okay? If there's trunk extensor weakness. And so that's another challenging test, and they even recommend here having a second person to perhaps stabilize, because now we're going to see the person trying to substitute, right? They're going to substitute this trunk extension for this cervical motion as well. And so I'll show you the positioning for that as well, because I think you can do it I think you can do it with one hand, but you can't really do more than a grade 3 because you have to use one hand to stabilize, right? You can't do the resistance component and stabilize at the same time because you have to have a hand under the head for safety. You guys follow me? So that's why they say you probably need a second person if you really want to assess somebody who has trunk extensor weakness. So let's go ahead and get it started here. You guys can see that there. Right. All righty. So in this particular case, I'm going to have Chris come up. Maybe Scott can take over on the camera. Same type of thing again. Let me get my gloves on first. Hang on a second. So because we're in that T-zone, like I said, gloves or hand sanitizer before and after. Guy's living dangerously here, isn't he? And so, shoulders off. Come forward for me just a tad there. Perfect, right about there. My one hand's going to be my right hand in this case, he's under the chin. My left hand's going to be positioned on the occiput here. Okay? Position on the occiput. And for the first movement, I'm going to ask him to bring his head up and back, but I want him to keep his eyes down on the floor. Keep my right hand here, so bring your head up and back. Cervical extension, bring your head up and back. Perfect, and come on down. Just try one more time. Keep your eyes on the floor though. Perfect. There's my cervical extension right there. Okay, relax. And now we're going to go ahead and we're going to apply moderate resistance right to the occiput. So now I'm going to apply some resistance. I want you to go through that same motion again for me. All the way up. Good, and back down. So there's my moderate resistance there for a 4. For a 5, we're still going to apply that resistance through the range, but now at the top, we're going to ask him to hold for that slow count of 5. Come on up for me, all the way up as high as you can go. Good. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5. Come on back down. This is a tough movement. I'm going to ask him to make sure he keeps his chest on the table. Okay, so don't lift the chest up. One more time, come on up for me. Just look up toward the ceiling. There you go. Perfect. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5. There's my grade 5. Okay, slide back on the table. And lie on your back for me. Oh, flip back around. Let me show you how I would do the technique if I was going to try and for trunk extensor weakness. So I would flip my hand placement again, right, and I would stabilize him here, right? So try and come up, but try and bring your shoulders up at the same time. You'll see something looks something like this, right? They're trying to come up, but they're weak. Their neck and their trunk extensors are weak, and they're really, really working hard. So come on back down. If you see that, you're going to want to stabilize him here like this. And now I want you to bring your head straight up and back, looking down at the floor. So there's my 3. But again, I really can't do more than that because I'm going to need a second person because I have to have a hand under his head for safety, and I stabilize his trunk. Okay. Flip over on your back for me. And then for the, just lie back for me. I'm going to flip the book. Lower the table back down. So I'm going to do this on the stool. Right, and the command here is going to be try and push your head down into my hands, right? And I'm gonna place my hands again distal to the occiput, right? Iliocostalis, longissimus, semispinalis. I'm palpating those. You guys probably see those in the lab, right? So I'm at the base of the occiput here. Just going to work my hands down. You know, just find the spinous process and just come lateral to it, right there. So I want you to try and bring your head back toward the table. Good. So all you're looking for is a little bit of movement, you say, but how can you appreciate movement here, right? The table has a little bit of a give to it, so you're looking for partial range. Or if they can't do what we just did with their head off the table and prone, you're obligated to check and see if they're at least a 2, or if they can't move against gravity. So try that one more time for me. Perfect, right? And I can palpate, right, those cervical extensors with this movement as well, all right? If there's no movement at all, and I still palpate muscle activity, what grade is that? A 1. A 1. Again, are you going to see that next summer? Probably not in the clinics that you'll be in. But the summer after that, possibly. And that's important. Why are the cervical extensors important? Patients in a wheelchair, right? They cannot control their head from moving forward. That could be a real problem, couldn't it? And so that's something we want to make sure we're going to be assessing with those patients in that particular rotation that you're going to be on, okay? Any questions at all on any of that? All right, let's give it a go. Thank you, sir. Yeah, so you're trying to create like a little bit of a flexion moment at the upper cervical spine. Yeah, yeah. Because you're really trying to avoid, I gotta turn my mic off, but you're trying to avoid capital extension when you do cervical extension. How we doing on that? Any questions on that? Questions? How we doing on that side? Am I off mute? You guys hear me over? Can you guys hear me right now in this room? I don't think so. Maybe I'm still on mute. Can you hear me in there? You can? Okay. Okay. So remember, in order to be a 5, you have to go through full range, right? So on these practicals with your patients, to be a 5, you have to go through full range of motion. And so if you assess cervical range of motion and you see that they have 45 degrees of cervical extension and you're not going through all that, right? Because at the end range is where you're applying that resistance to see if they're a 5. So when you're practicing, make sure patients are going through full range. And it's hard for some of you to understand what this movement is, right? It's hard for some of you. So helping your patients understand that is even sometimes more challenging. Plus now the head's off the table, right? It looks like we got a footprint or something on this one, which I'm not real happy about. It's like a boot mark. What is that? You don't see it there? Yeah. If I stand here, you guys got to wipe that table down. That looks like something on there. Come here. Yeah. You can't see it from where you're sitting. Do you see it? Yeah, you guys are putting your face on that. And so make sure your tables are wiped down. Did you guys wipe these tables down yet? I'd wipe these tables down beforehand. What's that? I don't know, man. I don't know if that is. Looks like a boot print, though. Someone has a pretty funky hand if that's what that is. We got a break? Yeah, so we'll break. So let's talk to Dr. Bogalski here. What the best way to do this is. So what do you want to do? 1 mile. We're going to run a mile. We're going to run in formation. Formation run.
So we just apparently have to vacate the building. It's raining.
Yeah. All right, 10 minutes. Come back in 10. Right. See if they could just hear me over there, Scott. Bring people back in. All righty, we ready to go? So let's go ahead and review these movements again of the upper cervical spine. And so that backward nod, right, that backward nod that we spoke about, right, that's capital extension. This forward nod, right, is capital flexion, right? This is going to be an important movement. Again, upper cervical spine flexion, right, at the atlanto-occipital joint. That's where that's occurring. So we're talking about this movement right up here. That's what we're going to assess next. And one of the main concerns with this particular movement is that it's a concern because many of our patients have a forward head posture. And when they have that forward head posture, what's happening to the upper cervical spine? What position am I in with respect to flexion or extension and when I have a forward head posture? At the atlanto-occipital joint, I'm in a relative position of extension, right, at the atlanto-occipital joint. Flexion in the lower cervical spine, right? This particular movement here, this protraction type movement here, right? So there's extension at the upper cervical spine. And so that is a challenge in some ways, right, for folks to do this upper cervical spine flexion because they're very limited with that. When I'm in this prolonged position of upper cervical spine extension, I'm lengthening the deep neck flexors, especially with respect to capital flexion. And what have you learned about muscles that are placed on length for prolonged periods of time? What happens to their ability to generate force? Decreases, right? So it decreases. And so we're likely going to have some weakness in some of these muscles, okay? Especially if folks are in this forward head posture for prolonged periods of time, okay? The musculature here, it's important to know what they are, right? So it's rectus capitis and longus capitis. Those are our two prime movers for this capital flexion type movement. But this is the one movement that we need to be extremely careful with respect to our palpation for less than a grade 3. We're going to palpate and look for movements for grade 2s and grade 1s, but you want to be very, very cautious with the pressure that you put in this area because the carotid artery is here, right? And you don't want to get your patient to tap out, pass out on the table. And so if you palpate, and you can, right? If you palpate, it's going to be extremely light and you'll be able to feel that. So very light palpation and very brief when you're doing that. So we're going to position the patient in supine for all the tests, really. For all the tests, they're all going to be positioned in supine here. And so we're going to start the patient in this supine position. We're going to teach them, right, that nodding movement. That's what we want them to do. And we're going to ask them specifically to tuck your chin, right? Tuck your chin into your neck, right? And we're going to ask them to keep their eyes straight ahead. So looking straight up, right? But tuck that chin in toward your neck. Keep your head on the table as you're doing that. And that's going to be the command. If they can do that, that's a grade 3. Grade 4s and grade 5s, I'm going to cradle my hands like this and place them underneath the mandible just like that. And my resistance forces are going to be placed there. And I'm trying to pull up, right? I'm moving that cervical spine into that capital extension. That's going to be my force for that. Okay. So that's grade 3, 4s, and 5s. For grade 2, again, we're just looking for partial movement, right? Partial movement there. Partial movement, right? And then grade 1, again, you can palpate for contractile activity, but it needs to be brief, very, very light, and done with caution, okay? Because those are sensitive structures in the sensitive vascular structures in the anterior aspect of the neck, okay? Right. So any questions before we get started on this one? Capital flexion. Why doesn't everybody try and do that movement? Can you guys do that little nod at the atlanto-occipital joint? Let's see you guys do that. Lower cervical spine should be straight, meaning it shouldn't be moving at all, right? You should get no movement in the lower cervical spine. It's just that nod, right? That little nodding movement right there. Okay. Chris, you want to come up? Heads on the table for this. And we'll, again, when we get to lab probably next Monday, I just need to get through tonight, right? I took extra medication today just so I can get through this thing tonight. With 400 people in that Zoom room, I have no idea how that's gonna go. But I got Boggs in there with me, so it has to go good, right? I said, if you help me sort these Zoom rooms, breakout rooms manually, you don't have to be a facilitator. So how cool is that? He said, heck yeah, I'll do it. And so the movement that we're gonna try and facilitate is this upper cervical spine flexion, right? And we're gonna teach you guys how to do that manually. Because we can move the patient into that, we can mobilize that with that movement, we can do muscle energy techniques, and we'll teach you guys what those are. And so let me just have you do that movement right there. That's it, right? That little upper cervical spine flexion right there. That's the movement right there. So that's a 3. Give me a little bit more. You got a little bit more than that? Perfect. One more time. Good. So tuck your chin right in toward your neck and make sure you keep your head onto the table, right? That's the command. So go ahead and do that again for me. Perfect. Any more than that? Perfect. So there's end range right about there. So now to do a grade 4, I'm going to cup my hands, place them under the mandible right here. Okay, so go ahead and do that again for me. I'm going to apply some resistance with that. Good. So there's my 4. Do it again for me. Good. Full range. Relax. One more time. Full range. Good. So there's my 4. For the 5, I'm going to resist it, right? And then he has to hold for that slow count of 5 to achieve that grade of a manual muscle test for a 5. One more time for me. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5. And I'm really trying to bring his upper cervical spine into extension. That's my force with that. Okay. Grade 2 would be partial range. Let me see a little partial range there. Good. So I got a little bit. Give me a little bit more than that. Good. A little partial range there. And again, if you're going to palpate, come up underneath the mandible and just palpate there just for a second, and you can feel those upper cervical spine flexors. Okay, you can feel those. So you can do it really light and just, you're looking for no movement, but is there any palpable muscle activity? Okay. So let's try and work on this upper cervical spine flexion at the atlanto-occipital joint. Okay. You okay with a small? Is that an okay size for you? Okay, good. I don't know if we have extra smalls. You know what I mean? Right. Any questions on that? Sound okay over on the other side, Scott? I just want to make sure. I know Dr. Bogolski said that sound may have been an issue last class. Sound okay over there? Perfect, perfect. Okay. And so that capital flexion, again, especially in patients who have that forward head posture, we showed you several pictures of those last time in lecture. For patients who are stuck out here, that's a tough motion to get. Sometimes we got to work on trying to get some of that back, right? Those muscles in that suboccipital region posteriorly are going to be really, really tight, right? And so it's going to be very challenging for patients to do that. So some of the therapy that we're going to do in that case is to try and get some of that flexion back, that upper cervical spine flexion back, right? By doing some manual techniques, some soft tissue work, some joint mobilization, et cetera, to that posterior occipital region, suboccipital region. And so we're going to switch gears a bit. Now we're going to look at cervical flexion. Okay, cervical flexion, which is the flexion that all of you measured before. The one thing I failed to mention, I think the range of motion for each of these tests are important because we don't have you measure capital flexion and then cervical flexion separately, right? So in this particular case, that capital flexion, I failed to mention it, and I was making sure that all of you got to end range, right? Because some of you weren't getting there. Even when I was working with Chris, I mean, it's tough to make sure you get to that end range of that upper cervical flexion, but it's about 10 to 15 degrees. And then if we begin to think about this or cervical flexion, the reason we say 35 to 45 degrees because we're going to have the patient tuck their chin, and then we're going to have them flex their C-spine, right? Tuck their chin and then flex their C-spine, right? That's what we're going to have them do. And so we mentioned what the cervical capital flexors are. With respect to flexion of the cervical spine, the muscles that are most important here are going to be longus colli and sternocleidomastoid. Right, longus colli, sternocleidomastoid, those are going to be the prime movers for cervical flexion. Okay. And sternocleidomastoid is interesting because when we talk about grade 2s and 3s, you're going to get thrown a little bit. All right, grade 2s and 3s. So for cervical flexion, right, we're going to have the patient tuck their chin, right? So we're going to have them do that little upper cervical spine flexion and then lift their head up and forward toward their chest, right? So we have them tuck their chin and then lift their head up and forward toward their chest, looking to achieve, right, that range of motion of 35 to 45 degrees. That's going to be a grade 3, right? They can tuck their chin and lift their head up off the table, go through that cervical flexion full range. That's a 3. Grade 4, we're going to apply resistance, but we're going to apply resistance now to the chin, all right, to the chin. That's about C3, right? You guys talked to Lynn McInnes. When you didn't talk to her, but you listened to her. Lynn McInnes, she talked about upper cervical spine open mouth views, AP open mouth views. You guys remember that? Do you know why you're doing an open mouth view? Why you just can't do just a straight plain AP? Why do you have to do an open mouth? Because you got the jaw blocking the upper cervical spine. So you have to open the mouth up. And so that jaw mandible's about C3, right? So you're applying resistance at that particular point there. The hand on the chest is if there is weakness of the trunk, right? Weakness of the trunk, because the shoulder should stay on the table during this test, but if there's weakness of the trunk and the patient, or neck flexors, the patient may try and cheat a little bit, try and activate even some of the abdominal musculature. So if there's trunk weakness, you may have to stabilize. Okay. So grade 3, 4s, and 5s, we talked about those. Resistance given at the chin, just 2 fingers. You don't need a lot. If, however, the patient is not a 3, okay, if they're not a 3, we're going to switch to cervical rotation. And we're palpating the sternocleidomastoid. So what's the function of the sternocleidomastoid? It rotates contralaterally, right? And it side bends ipsilaterally, right? So if I rotate, we're going to have the patient lie with their head straight up on the table, and we're going to ask them to roll their head to the left, right? That's my right sternocleidomastoid that's activated when I do left cervical rotation. We good with that? You can feel that. So just gently, right? Don't put yourself into a sleeper hold here, but palpate sternocleidomastoid and rotate your head toward the left. You should feel that right sternocleidomastoid kick in. You guys on sternocleidomastoid? There you go. Rotate toward the right, that left sternocleidomastoid, you should feel it pop in your fingers. You guys feel that? Right? Basic surface anatomy here. Right? Okay. Questions on that? Questions on that? So we're going to switch to palpating over sternocleidomastoid and looking to see can the patient rotate their head. And for a grade 2, the patient can complete partial range. Again, if we're rotating toward the left, it's the right sternocleidomastoid that we're going to try and palpate. If we're asking the patient to rotate toward the left, okay? Questions with that? Right, so let's go ahead and get started here. So I'm going to have Chris lie on his back. Okay, just lie on his back. And again, I think the key to this is that we're going to have the patient do that little upper cervical spine flexion first, right? So we're going to have him tuck his chin, tuck your chin, and I want you to lift your head straight up, all the way up toward your chest. Keep your shoulders on the table. Perfect. Come on back down. So there's my 3. Tuck the chin and go ahead and lift your head up as far as you can go, keeping your shoulders on the table. There's my grade 3. We good with that? Come on back down. The reason we haven't tucked the chin is because don't tuck the chin, just kind of point your chin out and try and come on up. You could see this, right? We start to see these upper cervical spine muscles begin to compensate for that. So we want him to tuck the chin. We want to see that nice cervical flexion. So come on up now for me one more time. Bring your head up toward your chest, right? Shoulders on the table. Come on back down. For my resistance, same type of thing, but I'm going to just apply 2-finger resistance at the chin right as we go through that movement. So go ahead and tuck your chin and come on up for me. Good. There's my resistance through the range. There's my grade 4 and relax. And I'm going to switch hands. I'm just going to keep a hand just on his trunk, just for a little stabilization with this. So go ahead and tuck your chin for me and come on up again. Moderate resistance, hold there at the top. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5. Okay, just 2-finger resistance at the chin. Okay, I think it's fair to keep this here because as we're going through that grade 4 and grade 5, there's a chance that he may try and flex up at the trunk a little bit. Okay. If they can't do that, there's a good chance you may see patients who can't lift their head off the table. These muscles could be weak in these folks. Palpate sternocleidomastoid again, and I'm going to ask Chris to rotate his head. He went that way. I gotta get confused here. I get confused because sternocleidomastoid, if we're rotating the head toward the left, I'm gonna have him rotate. I'm gonna have you rotate toward the group. Rotates his head toward the left, right? It's his right sternocleidomastoid, right? That we should see activate. So go ahead and turn there, right? And you can see it right there. Come on back up. Rotate now toward the right, and I should see the left SCM right there, okay? Can you guys even see that? You guys should be able to see that. See it kick in right there? Come on back up. Now, if he can't rotate, I'm just gonna palpate. I'm gonna say, go ahead and try and turn your head toward the left, right? Try and turn your head toward the left, and you'll feel a little bit of SCM kicking on the right. And go ahead and try and rotate your head toward the right, and you'll feel just a little bit of SCM, right? Start to kick in on the left. Okay, so it's a contralateral rotator, and that's key. Questions on that at all? All right, let's give that one a try. Thank you, sir. So let's see here. We good on the other side? How we do on the other side? Any questions at all? A couple points, I think, just to mention. If Chris can just lie back down again, or have somebody else come up. This isn't something you need to write down, so I just need someone else. Just come up here for a second. I just want Chris to work the camera, so just lie on your back for me up here. On your back. And so just make sure, though, that you're going through full range of motion, okay? So go ahead and tuck your chin for me and bring that head all the way up. Good. We want full range, right? And so when you guys apply your resistance, right, because one of you is going to be a patient and we're going to tell you what grade you're going to be for the practical. And part of the practical is important. You guys want to do well on that, right? But part of that is that you're going to know you're a grade 4, right? And so if I'm here and I'm not letting her go up and she can't get through full range and I see her trying, because she's trying to earn a point for being a good patient. So if you guys aren't good patients and you don't know how to mimic the grade, you lose credit, right? And I'm not going to take it off of her, but I need to make sure that she can get through full range for a 4, right? And for a 5, I'm applying resistance at end range. So tuck your chin and come all the way up for me, right? So that's what I want to see. Now her shoulders are coming up, right? Come on back down. That's fine. That's fine. The command would be, let's do that movement again, but I want you to try and keep your shoulders on the table. And you don't necessarily have to drape your arm across. This is a sensitive area, and I mentioned this to a couple folks. Some of you had a hand right in the middle of somebody's chest. You always want to think about sensitive areas to begin with, right? And so all it is just some tactile cueing just onto the shoulder, right? I want you to go ahead and tuck that chin and bring your head up toward your chest as far as you can go. Keep your shoulders on the table, right? It's all she needs to hear. And that's going to be it. Okay, so again, for a grade 4, it's full range, regardless of the body region, right? Full range with resistance. Grade 5, full range with resistance through the range, but then you can hold for that slow count of 5. We good with that? And this is important because, range of motion and strength, that's our bread and butter, right? No one else is doing that. There's no other medical professionals that are looking at this, right, the way we are. And so if you make a mistake and you grade somebody else a 5 and there's actually weakness there, you probably missed something that's rather significant. You guys follow me with that? That's important. Thank you very much. Excellent. All right. So the book talks about assessing weakness in sternocleidomastoid. Okay, how to isolate it if you want to do that. Okay, and so what we're going to do, I'm going to ask Chris to come up. In this particular case, it's going to be cervical rotation to end range and then flexion. Okay, in that rotated position. Wait, it's really coming down, isn't it? I mean, I'm waiting for the locust to show up, right? What's it going to be? Rats, mice, skunks? We got skunks in the Lock City. You guys know that in Lockport. There's skunks wandering around. Skunks. All right, so let's take a look at this. And so this movement here, I'm going to ask Chris to turn his head all the way toward the left, as far as he can go toward the left. And then I'm going to ask him to go ahead now and bring your ear up toward your chest, as far as you can go, while maintaining that end range rotation. Okay, come on back down. All right, so that'd be a 3. And I can see his SCM. Let's turn this way. Maybe Scott can get a close-up of that SCM on the right, or left rather. So right rotation, left SCM is working. Now I'm going to have him rotate all the way as far as he can. Bring that left ear now toward your chest. And you can see that SCM right there. You guys see that? If you can't, you need to see it. Because you guys haven't flipped your cadaver over yet, so your cadaver is prone. Is that right? So you flip them over, I think, maybe in the spring. I don't know if you flip them.
Oh, they flip.
You do flip
Yeah.
them? Okay.
Yeah, for the shoulder.
In the fall.
Yeah.
Oh, shoulder.
And
Yeah.
then the anterior neck.
Forgot about that. Good. So you guys do anterior neck then. So you'll see SCM. So one more time. Come on up. Am I in trouble for something? 45 to 55 degrees. That's how it goes with my life. I see a woman walking toward me, I'm usually in trouble for a variety of reasons. Female cats, female dogs, daughter, lady friends, work colleagues. I'm never in their good graces. All right, so that's a grade 3. What's a grade 4 going to be? I'm going to apply some resistance just above the temple, okay? Not just above, right, just above the ear, over the temple, okay? And so I'm going to go ahead and come at it from the side here so I can keep an eye on them. The other thing about this rotational type position, we'll talk more about this, but these rotational end range type positions, if there is some type of vascular concern with the vertebrobasilar arteries, you could potentially cause some dizziness with these end range rotary type positions. So you'll have assessed that likely. You'll know if someone's telling you they have dizziness, but it's probably not a bad idea when you do rotate their head to the one side to be there, kind of looking at them, have them keep their eyes open. Don't know why just yet, but it's probably a good thing. So I'm going to have you go ahead and bring your ear up again toward your chest. Let's have you turn here. Bring your left ear up toward your chest. There's my grade 3. Shoulders stay on the table, right? 45 to 55 degrees of flexion we're looking for. Let's do it again with some moderate resistance here, all the way up, all the way up. Good. So there's my grade 4. For my grade 5, we're going to do the exact same thing again. Keep it end range rotation. And now I'm going to have you go ahead and hold up there for a slow count of 5, 2, 3, 4, 5. Okay? And best for me, he's a strong dude, right? Turn here like this. Turn toward me. We raise the table up a little bit. One more time. Turn here. Stabilize here. Come on up for me through full range. Right? I have a better mechanical advantage here now. 1 month out. Come on up. We're going to do a 5 again. He's trying to get out of it. You see that? Getting fatigued a little bit. Yeah, and relax. Good. Questions on that? Grade 2s and grade 1s are the same for the flexion component, right? So I'm going to be here, and I'm just going to ask the patient to rotate their head, right? So rotate toward the right for me, right? Left SCM. Seeing people just running in. It's going crazy here. Rotate toward the left, right SCM. Partial range, 2. No movement, but palpable muscle activity, a 1, okay? But make sure you're palpating over the SCMs, okay? Questions on that? Easy enough, let's give it a go. Almost done, almost done. Right. So a good question was raised. I'm not sure. They all set on the other side? Yeah. A good question came up that when you learned manual muscle testing, the basic concepts of it, that for grade 2, you put patients into a gravity eliminated position. So we teach the hip in the spring, a grade 2 for hip flexion, right? A grade 5 for hip flexion would be that I can have the patient sit on the edge of the table, flex their hip all the way through full range, and I can apply resistance to that. Grade 2, I'm going to position the patient side lying with the side I'm testing in the superior position. And I'm going to cradle the patient's leg. I'm going to ask them to bring their knee toward their chest. That's the concept with manual muscle testing. You put them in a gravity eliminated posture. We don't do that for the C-spine. And there's reasons for it. The book talks about it. They give a good explanation, but we don't do that. And so these grade 1s and 2 postures mostly are for the safety of you and it's for the safety of the patient. Okay. And again, these studies have been done. They look at electrophysiologic, electromyographic activity of these muscles, and these postures seem to work for that. Last one we're going to do is cervical rotation. Okay, cervical rotation. So the key here is going to be we're going to position the patient. They don't have pictures, which is unfortunate because this is the one that's tricky. Because for a grade 2 for cervical rotation, we get the patient out of the supine position into a sitting position. Okay, into a sitting posture. And we ask the patient, can they rotate, right, in a sitting position? Why they don't do it for the other ones, I don't know, right? But for this particular position of cervical rotation, the patient goes into sitting if they don't have a grade 3, if they're less than a grade 3. And so for grade 3, 4s, and 5s, we're going to position the patient supine, right? And for rotation, we're actually going to have them turn their head, right? So if I'm going to assess right rotation, I'm going to position Chris's cervical spine in left, full left rotation, and I'm going to ask him to rotate his head toward the right. You guys got that? So as he's rotating his head toward the right, and they list the muscles here, right? There are several of them that are involved with this particular movement, okay? And so let's go ahead and do this. So Chris, you mind coming up? And we're going to apply resistance for grades 4s and 5s, just like we did before. All right, so I'm going to have Chris turn his head toward me. And again, the book isn't completely clear. It says standing at the head of the patient, or it says facing the patient. I think facing the patient again, because anytime we start to rotate the neck, there's always something that probably is going on with those vertebrobasilar arteries. So you want to be concerned about that. So we're going to have the patient rotate toward me. And then what I'm going to have him do is, can I have you turn your head toward the left, just to the point where you're looking straight up toward the ceiling. There's a 3 for left cervical rotation. We good with that? One more time. Turn. Good. There's a 3. Okay. To resist it, turn toward me. This time I'm going to apply a little bit of resistance. I'm here. My head's just above the ear on the temple. Go ahead and rotate again for me, just to that point again. So there's my grade 4. Okay. Rotate again toward me. Full cervical rotation again. Just a little hand here for stabilization. My grade 5 would be, again, he's going to rotate up, look straight up toward the ceiling, and I need you to hold it there. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5. My force isn't necessarily in the frontal plane. I'm trying to keep my force in the rotary type plane, transverse plane force. So I'm actually doing this, trying to do this type of a movement, right? This type of resistive movement. So I'm going to resist him again one more time. Good. And I'm trying to rotate him toward the right with that. Okay, so that would be left rotation. If he can't do that, right? So if he can't turn his head out of that posture, right, we're obligated to see, is he at least a 2? And so in that particular case, they say put the patient into a high back chair. Okay, I really don't have a high back. We can't bring them in. If I bring in a high back chair, I got to ask one of you to leave. I'm not a huge fan of these. I got to be honest with you. I mean, I would almost rather have the patient sitting on the plinth than use this, right? Because this is, you can't sit back into this. The whole point of the high back chair is that you're supporting the spine, right? So think about a patient who can't rotate their head. They're likely going to be in a wheelchair anyway, right? So you're going to assess that posture. And so just like we talked about before, I'm going to make sure that the high back chair is supposed to get him into a good lordotic posture with respect to the lumbar spine, right? Thoracic spine is now stable. And I'm going to ask the patient, can you rotate toward the left for me, right? Any movement at all, right, is going to be a 2. Can you rotate toward the right for me, right? And you want to do both sides, okay? Palpate. I always think palpating, I know Dr. Boggs taught you guys how to palpate the thyroid. I'm not exactly sure how we did it, but to palpate the anterior neck, if they're in sitting, I like to do it posteriorly, right? So I have my fingers right here over the sternocleidomastoid. Again, if I ask Chris to rotate toward the left, right SCM should pop into my fingers, right? Rotate toward the right, left SCM should pop into my fingers. So he may not have any motion here, right? Let's say he is in a wheelchair, right? High level quad, right? He may not have motion, but I'm looking to determine, does he have any palpable muscle activity at all? All right, we good with that? Questions on that? All right, we got a few minutes left. Let's finish that one up. Thank you, sir. I appreciate you being here too, man. I'm glad you applied for this. It's good. Yeah, thanks for doing that. Okay, so as folks are finishing up, let me just mention a couple things before you guys start to scurry on out of here. Wipe the tables down really well. Do a good debris check in both rooms. Anything on the floor, make sure you pick it up. Chairs should be put back underneath the tables or as close to the tables as we can. And then make sure you guys wash up really well before you go wherever you're going next, okay? So do a good hand washing at some point. Tables wiped down, chairs wiped down, chairs pushed underneath, and then wash up, okay? Good job today. All righty. How we doing on the other side there, Dr. Bogalski? She can't hear me. You guys can hear me. That's what I was hoping she would hear something over there. Any questions on anything? Can you see, can you guys look over there and see if someone could raise a thumb, see if they can hear me there? Can they hear me? Sweet. Anything you want to add before I get started? Unbelievable, this rain, huh? It's doing wonders for my herb garden, though. My basil and my parsley and my oregano, my thyme. I have to be careful, though, because this rain could trash it. Nothing like fresh herbs. You guys got a herb garden going? No herbs? No herbs. All right. So we do have to finish up with some range of motion measures. The one measure that we ended on last time was cervical rotation, and we used the standard long arm goniometer for that. Okay, and how much motion did we say you have with that standard long arm goniometer technique? Do you remember? How much? 60 degrees. Yep, for standard long arm goniometer. And so for this particular technique, I think it's quite useful. We don't, you know, at least I don't. You can. I don't typically treat patients for cervical spine disorders in sitting. And so to reassess that, I would have to take my patient from the supine position into a sitting position to reassess it. But with this particular technique, right, we do a fair amount of manual therapy techniques and other techniques in the supine position. So within session, this is really very helpful to determine if you're making changes in the patient's range of motion. This just doesn't seem to fit very well on here, does it? Right. Okay. And so you're going to get a measure with this. Understand that it's not consistent with the measure that we gave you because that measure of 65 degrees was for the standard long arm goniometer. Do you mind working the camera for me? Do we have anyone else here? Or is this it? Wait, so we have Jen Bogalski. Is anyone else around? It's supposed to be 3 people? Who's in this room? You're not in this room, are you? Who's, oh, Clay. Clay's the other person. Why is he on that side? Yeah, just wants to look good. Stay out of my way here. He should probably be working the camera. This is the new normal, I guess, huh? The new normal. And so for this particular technique, the patient's going to be supine, right? And we're going to go ahead and assess cervical range of motion in the supine position, okay? Any neck pain at all? Go ahead and just sit up for me just so I can see your range of motion. Just face me here real quick. Just let me see you move. No pain? Turn toward that side for me as far as you can go. Good. Turn toward this side as far as you can go. Excellent. Go ahead and lie on your back for me. And so when I position the goniometer, the inclinometer, it's going to be right on the forehead here. I'm going to zero it out. Right now, I'm going to ask the patient, I'm going to maybe watch it first. So have you go ahead and rotate your head toward the right for me as far as you can go. Good. Any pain associated with that? Good. So go ahead and do that again for me. Rotate all the way toward the right. And I'm going to keep my goniometer there. You're a lot younger and more mobile than me. Do you mind reading what that says? My glasses are fogging up. It's probably going to be about 80, 90 degrees, maybe more. Yeah, the inside number.
That one?
Yeah, what is it?
Oh, yeah. That's very
85 degrees. Okay, of rotation. Okay, now I can't change that out interchangeably with that long arm goniometer. So if you're using this technique, stick with it, right? Because again, we're going to teach you techniques in this supine position, so he does not have to change positions. This makes life very easy. Okay. Zero it out. Rotate toward the right as far as you can go. Do you mind checking for me there? See what we got. 80? Okay, 80 degrees. Right, let's say he only got to maybe about here, rotate to here, right? He goes to here and he says, that's where my neck pain is, right? I'm gonna look and see what that is, right? That's at 30 degrees. I'm gonna bring him back up. I'm gonna treat him in this position, right? Treat him in this position, and I'm gonna go ahead and reassess that. And I could reassess. How much motion would I wanna see an improvement of before I would think it's kind of beyond that measurement error that we spoke about and just individual patient variability? Minimum probably 5 degrees. I think with this thing, probably 10, right? I'd probably want to see a change of at least between 5 and 10 degrees. Over 10, I'm really feeling confident that I made a change, right? Less than 10 with this, right? These bubble inclinometers, there's positioning like that. So you'd probably want to see a change of at least a good 10 degrees. Does that make sense? There's variability with him. If I have him do that movement several times, and I'll be honest with you, if I was going to do this for a range, if you look at my patient note, which I don't keep very good, no one's paying, and I can pretty much do what the hell I want. Insurance company breathing down my neck. I will take, typically, if I'm looking at a range of motion measurement, and I didn't mention this to the last class, so really upset them and say, Ross is dropping pearls that you didn't get. 3 measures, right? And then take the mean of it, right? And I don't even average them. I just write the 3 measures out, right? So I would do that 3 times and just write them out. You don't even need to take the mean. That the more a patient does a movement, right, there's going to be more movement likely associated with it. And you want to get to the point where you feel the movement is stable. We good with questions at all? All right, let's give this one a try. Thank you. Thank you, Dr. Boggs. guys doing all right with this? All right. So range of motion measurement as we taught it here was just, we're looking at that one single motion, one single plane, and we're measuring how far the patient can get. Again, I think clinically, if you're going to pull a goniometer out, we're not going to ask you for a practical. I think there is some usefulness to taking 2 or 3 measures to make sure the measure is stable. Because if I look at Blake's rotation, he goes from 70 to 75 to 80. What does that tell me about that measure? Every time he does it, he's getting a little further. So either my command is not appropriate, that I need you to get to end range as far as you can go, or each time he moves, he may get a little bit more motion out of that, right? And that sometimes can happen. So you want to make sure the motion's stable. Okay. We will talk about repeated movements. Those are important. What's going on? Can you hear me? Oh, there we go. But why are you on this side? Can you work the camera? He's not even on the clock. And he ain't getting overtime. Can you do it? Can one of you guys do it? He's not on the clock. Look, man, if he doesn't graduate. Absolutely, man. Go write a paper box. Go do an EMG or something and go write a paper. So now I'm confused where I was. Oh, the great Dr. Case, full-time clinician. We're grateful to have him in here. I don't know when Dr. Coleman is around, but he's another full-time clinician. Scott Tansky is another full-time clinician who helps us in the lab. So we're grateful to have the clinicians in the lab. But Clay, I mentioned this before, has some advanced training and in looking at repeated movements, right? So those movements that we did with respect to goniometrics, we're doing those as a comparable sign, right? I reproduced the patient's symptoms with it, and there's limitations that I think are of some importance. So if I increase those movements and make them less painful, hopefully that's going to correlate to an improved outcome, right? That's the whole game plan here. And remember, when we look at range of motion, it goes back to that mobility classification that we have from that child's paper. Decreased range of motion, we're likely going to put our hands on the patient, mobilize some different segments, maybe do some soft tissue work, maybe some stretching, and go from there. But repeated movements, again, are going to be important. And I mentioned this in the last class. What group? Let's talk about a patient profile. How would that patient's body chart look that we're going to really focus on repeated movements with? What would that patient have? You read it in that child's paper. You guys are all looking away again. I can see it. Cervical spine, we really aren't worried about that right now. You guys read the paper? What'd they say about centralization group? What patients are you really going to focus on for that? With respect to their body diagram, where are those symptoms going to be located? You guys are doing all the time. It's just like a reflex. You guys just look away. A little torticollis, a little wry neck there. Give me something, anything, maybe from the other room. They have radicular symptoms, so they have distal symptoms, right? And someone said in the last class, maybe they have referred symptoms. Maybe, right? But there are symptoms that are away from the cervical spine, right? There's symptoms going into the extremity, right? And those are patients for sure that we think that if we move those patients in a specific position and we can move those symptoms more proximally, that's going to be important, right? And you want to make sure those patients are in that category so we can work on that. So Dr. Case is going to be kind enough to put us a video together. That's going to allow you guys a chance to work through that, and we'll practice it in lab a little bit as well, okay? So those repeated movements are going to be key. And if you haven't read that paper, you should. I know you guys had some exams, but read that paper, okay? And so we're going to move into strength assessment now. We've done range of motion. We're going to move into strength. If you're following along on that lab handout, there's a lab handout that I know you guys made copies of. After range of motion, it talks about repeated movements. That's where Dr. Case is going to come in. But now let's move on to strength, Okay, so strength assessment. With respect to the cervical spine, at least in the sagittal plane, right, we're going to look at flexion and extension. And flexion and extension can be dichotomized into flexion of the cervical spine from like C2 down, and flexion of the upper cervical spine. Flexion extension of the upper cervical spine. So we call that capital flexion and capital extension. So what movements are capital flexion, capital extension? Or where do those movements occur? Like what joint do we see these movements happening? Do you know what joint? I know Dr. Ford talked about it because I hijacked a copy of his handout. He makes you guys handouts, which I make handouts for people and I get yelled at because the PT department has to pay for it. So that's why I'm not making you guys handouts, but now make you guys handouts. I'm still not going to make you guys handouts because I came from the military program. Guess what? You made handouts, you were in trouble. We were completely paper free. Handouts, trouble. Totally green. I didn't think you guys like handouts. You guys love handouts. I get it. No problem. No problem. Where does that motion occur? What joint? Flexion, extension. Nope. I'd like to say, yeah, you might have a little up. You're going to get flexion, C2, C3, but capital flexion, capital extension. Atlanto-occipital joint, right? The OA or the AO joint, whatever you want to call it, atlanto-occipital joint, but it's occiput on C1, that little condyloid joint. And if you're not familiar with it, pull out the skeleton, take a look. Take a look how that skeleton, right? Take a look how that head sits on top of C1. How does the occiput sit on C1, right? You get a little side bending, but we're talking about this little flexion extension motion right here. That's all it is, little flexion extension motion. Everybody do that. So we're trying to get upper cervical spine so you do not move your neck. Right, we're not flexing our C-spine, we're just flexing forward and extending back, right? Occiput on C1, you guys got that? So flexion forward, extension back, right? Flexion, extension, flexion, extension. That's what we're looking at for capital flexion, capital extension. And these are important because we have patients who are out here with that forward head posture, right? Forward head posture. What position is my atlanto-occipital joint in now? Flexion or extension with this forward head posture? Complicated kinesiology here. What position is my atlanto-occipital joint in as I'm in this forward head posture, like many of our patients are? I showed you guys like 10 pictures. That one guy was a patient I treated during COVID. The guy with the really, really bad C-spine posture or T-spine posture. He had middle back pain. Can you imagine why? I said, just take a picture of how you sit. Lab guy. What position is this? Give me something, anything. Just give me a word. Extension of the upper cervical spine. That's right. So extension of the upper cervical spine, right? That's going to be important because when we start thinking about flexion of the upper cervical spine, that's going to be very challenging for many of those patients with that forward head posture. Okay. Also, I mentioned about that headache classification group, right? That's typically going to be related to the atlanto-occipital joint and the atlantoaxial joint. So these are joints we're going to evaluate in patients who have cervicogenic headaches. So we have to get these patients from this position, right? We have to get them back into the point where they can flex their atlanto-occipital joints, okay? And so on top there, that's what we're going to start with. Capital extension. We're going to start with that movement right there. And so for capital extension, we always start with what muscles. Your book does a great job of this, right? So what muscles are involved with this? The two biggies, the reason I think they're important is because when we get down below a 3, right, so the patient can't move, they don't have full movement against gravity, we're going to take them, to a different position, and we'll talk about what that's going to be. But we're worried about splenius capitis and the rectus capitis muscles, because we can palpate those. So when we get down to a 2, we're looking to is there movement? And then a 1, is there no movement? We can still palpate muscle activity. You should be able to palpate some of these muscles. So splenius capitis, it's a little bit lateral. Rectus capitis is important because we can find the spinous processes and just move our hands just lateral, and we can feel those muscles contract. Okay, so splenius capitis and the rectus capitis muscles are going to be important. We're going to position the patient for this particular test for capital extension in prone, and their head's going to be off the table. And so a couple rules with heads coming off tables, right? We have to maintain contact with the patient at all times. Okay, with the head off the table, there's a safety concern with that, right? So heads come off tables, we have to have a hand under the patient's forehead or chin the entire time, and we're going to place that protective hand underneath the chin. Okay, so that's what we're going to have to work with that. Because we're in that T zone on patients, right? T zone, right here, eyes, nose down to mouth. We're in the T zone, even though the patients are, you guys are all wearing masks. Your patients would have masks. I'm wearing gloves. Okay, I'm going to wear gloves for this. If I'm doing this with a patient, I'm probably going to wear gloves in the clinic. Your call if you want to wear gloves, or if you're not going to wear gloves, you need to hand sanitize prior to touching the patient, or in this case, your colleague, right? And then you need to hand sanitize immediately after. Okay, so those are the rules for this particular lab, okay? When we position the patient in prone, head off the table, you can see here, the shoulders are just at the top of the plinth, right? Any more than that, right? They really don't need to be too far off. They're gonna maybe feel unstable, so shoulders are stable. They're supported by the table and the plinth. The other point here is that when we do the movement, if patients have trunk extensor weakness, you may see, right? You may see them trying to elevate, right? Their shoulders coming off the table. And we don't want that. So shoulders stay on the table for this particular test. And so the command that we're going to give for this is we're going to make sure the patient understands that we're looking at this posterior movement here, right? This little bit of a backward nod. That's all we're looking for. How much motion is that? Right? How much motion for extension did we say you guys should have? How much motion? Cervical extension. How much? 45 degrees is what we said. For this upper cervical spine motion here, we're looking for about 25 degrees, right? And then the rest of the C-spine is going to contribute the rest of that. But there's a fair amount of extension in the upper cervical spine, okay? And so the command here is going to be, right, we're going to have the patient in that prone position. We're going to ask them to look up at the wall, right? Look up at the wall, right? And hold it. All right, so we want that patient to do that little bit of a backward nod and look up at the wall because they're in prone. And we just want to see upper cervical spine extension. We really don't want to see the lower cervical spine engaged in this particular case. All right, so let's give it a try. You want to come up, Blake? Any neck problems? No neck problems? So I'm going to show the 3, 4, and 5 in prone. If the patient can't complete the grade 3, right, we're going to move the patient into this supine position here, right? I failed to mention this earlier in the last class, but when you learn the principles of manual muscle testing, you learn that less than a grade 3, we put them in a gravity eliminated position. We're not going to do that for the C-spine. All we're going to do is have the patient in supine. We're just going to ask them to tilt their chin up, right? Tilt their chin up, or look back at you, keep their head on the table, right? So that's really the command we're going to give anyways. It's really tilting their chin up, looking up toward the wall in that prone position, and we're going to apply resistance through the movement. Right. Okay. So I'm going to raise the table up so I get a good mechanical advantage here. And so for this particular technique, we're resisting that sagittal plane movement, right, at the atlanto-occipital joint. And so I want to have my hand positioned at the top of the occiput, right, and my forearm is going to be in line with the thoracic spine. So I'm going to make sure I get him up in a good posture, because once I slide him out, right, my left hand is going to come underneath his chin, right, for safety. So maybe slide yourself forward, get to the point where you have your shoulders off the table. Perfect, just like that. And I'm going to have my fingers just underneath this chin here, right? And so my resistance when I do it is going to be here. And I'm resisting this movement here, right? So I'm trying to actually get that atlanto-occipital joint almost into some flexion, right, with my resistance. That's going to be my point there. So the first thing I'm going to have you do is I'm going to have you try that little backward nod position, just in this position right here. Perfect. And come on back down. Not a lot of movement here, right? But you're going to look up toward the wall again for me. Let's see that again. Perfect. Just like that. So there's my 3, right? For 4, now I'm going to apply some resistance to it. Moderate resistance. So I'm going to apply resistance through the range. Try it again for me. Good. Back down. Good. So that's moderate resistance. That would be a 4. For a 5, I'm going to apply that same resistance, but now at the end of the range, and he has to go through full range. At the end of the range, I'm going to apply a slow count of 5, okay, for my resistance. So come on up for me. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, and relax. You good with that? So that would be a 5. Full range, capital extension. Go ahead and lie on your back for me. If he couldn't do a 3, we're going to position him supine, okay? And again, I want to make sure you guys can palpate these muscles. Okay, so slide up toward me just a little bit right there. Perfect. So your fingers are going to be placed right at the base of the occiput. So palpate the occiput, right? And then just move them just down so you're right on the musculature. Your index fingers will be lateral. That's where you can palpate splenius capitis. And my middle finger, I'm going to palpate the spinous process and just come lateral to it. That's where the rectus capitis complex is. And I'm going to ask him to go ahead and look back toward me. Good, relax. So if he has any movement at all, that's a grade 2. If he doesn't have any movement, right? No movement, but I can palpate muscle activity, that's a 1. That's a 1. Okay, so go ahead and do the movement for me one more time. Good, come on back. All right, and you can palpate those muscles in that region. Any questions on that? Give it a try. Capital extension. Thank you, sir. Yeah, man. All right. How we doing? Okay? Good. They good on the other side, Blake? Take a quick peek. So again, just a couple things here. You okay? Okay. You're leaving? Oh. Test at 2:30. What class? Oh. Well, let's wish Blake good luck. Motor control. All right. So let's go ahead and talk about cervical extension. Okay, we've talked about the capital extension. The key here is going to be make sure that, I'm not sure where this camera's pointed, but make sure that when you guys are assessing capital extension, there shouldn't be movement occurring at the cervical spine. It's just that little bit of a posterior nodding motion. That's it. Okay, upper cervical spine. So we're going to go ahead and assess cervical extension next. And for cervical extension, you guys will be able to dissect these out, right? The prime movers for this are going to be iliocostalis, right? Longissimus, and semispinalis, okay? Iliocostalis can be most lateral, followed by longissimus, and then semispinalis is going to be most medial, okay? Those are going to be your prime movers. The motion for this particular test is about 30 degrees. Why? Because we've already taken up that motion at the upper cervical spine. And so for this particular test here, I'm going to have one of you guys come up and demo for me. Okay. Have you guys come up and demo. Same type of thing, right? Same type of positioning as before, except in this particular case, we're looking at cervical extension range of motion, which you guys are really good at doing, right? We're looking, just lifting your head straight up and back, but we're going to ask the patient to look down at the floor. Why? Because it maintains that upper cervical spine in a good neutral posture, right? Because we're no longer really assessing that. So we ask the patient, keep looking at the floor. It keeps that little bit of a flexion moment at the atlanto-occipital joint. And then we're looking at full cervical extension, okay, full range. Grades 3 through 5 are going to be in prone. And then grades 2 and 1 are going to be in supine again. And so we're going to have the patient lying supine for this particular test for grades 2s and 1s. We're going to move our fingers distal now off the base of the occiput because we're palpating for those muscles that we mentioned before, iliocostalis, longissimus, semispinalis, right? And you can see those muscles when you dissect out in your cadaver. Okay, again, a grade 2 is going to be minimal motion, some motions occurring, right? And we're asking the patient to try and push your head down into my hands, right? The table has some give to it, so you can get a little bit of movement associated with that. Again, a 0 is contractile muscle activity, but no movement. All right. So let's go ahead and give this a go. Thank you for volunteering. I'm assuming that's why you're sitting there. Any neck pain? Okay, good. Well, I'm going to just go ahead and check her range of motion. Just go ahead and keep sitting here for a second. Sit up nice and tall for me. Go ahead and look up toward the ceiling for me. Any pain with that? That's perfect. That's the movement we're going to check. That's it. It's like perfect. Better than Blake. Don't tell him I said that. He's worried about motor control, man. That's contamination, right? This is orthopedics. No, it's all the same stuff, right? I learned more from Dr. Fran Joan treating patients today. Orthopedics, Dr. Held and Dr. Fran Joan, they were the best. I had to take their class 3 times each in PT school, but that's okay. Go ahead and lie prone for me. Any neck problems?
Nope.
Okay, good. So I'm going to have you scooch forward for me, just to the point where your shoulders are right at the edge. So again, I'm going to have my hand underneath the chin for safety purposes, except this time I'm going to switch it because my other hand now is going to come here. Okay, so at the top of the occiput. So the first movement I'm going to do is keep your shoulders down on the table, and I want you to bring your head straight up and back, but keep looking straight down at the floor. So bring your head straight up and back for me. Perfect. That's it. One more time. Good. So there's my 3. Full range. One more time. Come on up. There's my grade 3. Now I'm going to apply some resistance all the way through the range. Go ahead and come on up for me. All the way up. All the way up. Moderate resistance. Let's do it one more time. All the way up. All the way up. You see your shoulders coming up. One more time. Keep your shoulders down. There we go. Come on back down. Slide your head back up. I'm going to raise the table up on here. My quads are getting a little too good of a workout there. My left quad. I don't want to get too much exercise in with you guys. All right, one more time. All right. So now we're going to do a 5. Shoulders down, right? Shoulders down. Go ahead and lift that head straight up and back, all the way up. Perfect. One more time. They got to hold it there. All the way up. All the way up. 1 1,000. 2 1,000. 3 1,000. 4 1,000. 5. Perfect. Okay. Slide back on the table for me. The one other thing here that I need to mention is that you saw her shoulder starting to come up. If we continued to see that happening, even after we started to cue her, we would have to stabilize her. Because the book talks about if patients have trunk extensor weakness, you have to stabilize. And if they have trunk extensor weakness, you likely need another person to really help you assess anything more than a grade 3. So this is the position that they recommend. So come on with your head off the table one more time here. If she has trunk extensor weakness, I have to stabilize here. Now I can still assess for a 3, right? So go ahead and lift your head straight up and back. Perfect. And come on back down. So I can assess for a 3, but I can't apply resistance because now I have to stabilize her trunk. So slide back up for me. So the book mentions that you may need a second person to assess that if there's trunk extensor weakness. Is that fair? Flip over on your back for me. And now for grade 2, supine, because I have this wonderful table, I can just keep it right here and standing. I'm going to move my fingers just distal to the occiput. So now I'm just lateral to the spinous process, and you guys probably can't see very well, but I'm here. And I'm just going to ask her to push her head back into my hands. Good. So try and extend your neck. Good. And relax. Good. Push back for me. Good. So I'm feeling a little bit of, I'm certainly feeling muscle activity, but I'm going to ask you to go ahead and extend for me. There you go. And relax. One more time. Good. So there's some movement there. And I also have palpable muscle contractions. If there's no movement, now I'm palpating for muscle contractions along those muscles we spoke about before. Fair enough? Yeah. Go ahead. You are too? Capital extension. Cervical extension. I don't have much. Capital extension. Cervical extension. So capital extension just occurs at the OA joint. That's it. Because what happens at the AA joint? Rotation. That's right, rotation. So capital extension is just going to be this. What you guys measured with your goniometer is cervical extension. Right, so cervical extension would be, go ahead and sit up. That's cervical extension. Do it again. Good. And come on back up. Capital extension is what? Just that. That's it. No movement here at all. Right? That's a challenge for your patients because guess what? You're going to have patients in this forward head posture. And that's a joint you're going to have to address either manually, right, or through some type of therapeutic exercise. You guys good with that? Does that help at all? Yeah, your cervical extension, cervical flexion, that's the stuff you guys have been measuring. We may need to take a break. No, we don't. Not yet. We started at 35. Is that right? So we have 6 minutes. Okay, so I got to take a break at 6 minutes. No joke. All right, so let's get this done. 6 minutes. Thank you, Dr. Case. It's good to have you back. All right, you guys ready? How was your break? Cold, my God. Cold. You guys ready to go on that side? Yes. All right. So let's go ahead and move into flexion. You guys looked like you were doing pretty well with capital extension. Now capital flexion is a little chin tuck, this little nodding motion, right? Happens at the Atlanto-occipital joint again. For this particular test, the prime movers for this are going to be the rectus capitis and longus capitis muscles. And this is a movement that is a challenge for some patients, especially if they have a forward head posture, right? Forward head posture is going to place these patients into upper cervical spine extension, and they could have some limitations into this upper cervical spine flexion motion. Not a lot of movement, only about 10 to 15 degrees for this. We'll make the rest up when we check cervical flexion, right? So only about 10 to 15 degrees of motion for this. With respect to the test, I'm going to have the patient in supine for this, right? They're going to be in supine, and I'm going to ask the patient to tuck their chin into their neck, but keep their head on the table, right? So tuck your chin down into your neck. That's the command, right? If they can do that, they're a 3, right? To assess for a 4 and a 5, I'm going to interlock my hands, right? I'm just going to basically cradle my hands and just come up underneath the jaw, just underneath the mandible, and that's where my resistance is going to be placed for a grade 4 and a grade 5. Okay, and then for a grade 2, any motion at all puts them into a grade 2. And then for a grade 1, this is the one, for a grade 1, you have to be real careful about palpating the anterior aspect of the neck because the carotid artery is there. So if you're there, very, very light palpation for those deep capital flexor muscles. So very, very light palpation, and don't hang out there for a long period of time. Just minimal pressure, okay? So does someone mind coming up here? Somebody mind coming up? Anybody? Yeah, am I gonna go up on your couch with my shoes? I don't know, someone had stiletto heels on last year and they punched a beautiful hole in the table across the way, and that pisses me off. Thank you for taking your shoes off. Or as I like to say, doffing your shoes. On your back, sir. You just want to do capital flexion, don't you? You do, don't you? I can tell. Let's see what his capital flexion looks like. Let's see it. Is that capital flexion? Did you just do that on purpose? OMG. Let's see that again. He's making me work, Dr. Case. You guys are killing me. So capital flexion, relax, is that. That's capital flexion. Guys, see that? 10 to 15 degrees. That's it. So try that little nodding motion. That's it. Just tuck your chin, right, down and toward your neck. Keep your head on the table. I think he's getting it, but he has that little platysmus thing going, doesn't he? They warn you about the platysmus face. It's like, platysmus face is like if I could drop my mask. What the hell's going on here? Got that look on your face. So not platysmus. You're really having trouble with these, aren't you? That's it right there. Let me see one more time. Right, tuck your chin down in toward, perfect. That's it right there. Okay, that's it. Not a lot of movement, but it's that little chin tuck right there. But you can see he's a bright guy, right? Bright guy, challenging movement. And again, your patients are going to come to you and people are already asking, well, what do we do with pain? You can do upper cervical spine flexion extension. It's likely they're not going to necessarily have pain with that, right? They're going to have pain in their neck, right? But you can start to work on these motions, right? And begin to get these motions back. But this is a particular strength test. So that's automatically a 3. Let's see that one more time. Good. So there's the motion, tucking his chin anteriorly. And then for the resistance, I'm just going to place my hands underneath the mandible here. So I'm going to have him do it again, and I'm going to resist that, okay? I'm resisting that. So there's my 4. For a 5, I'm going to ask him to resist it and hold, okay? So go ahead and pull down, resist and hold. 1, 1,000, 2, 1,000, 3, 1,000, 4, 1,000, 5, right? There's my 5. A grade 2, okay, would be any movement at all. So let me have you try that one more time. Tuck your chin down in front of your neck. Perfect. Keep your head on the table though. Any movement at all would be a 2. If there was no movement, right, I would gently palpate. Just come up underneath the mandible rather, and you're looking for those deep neck flexors. And one more time, go ahead and give it a try. And you can just feel those muscles start to kick in, okay? And so palpation, light and brief for this one, okay? Don't hang out there for long periods of time. Any questions on that? Upper cervical spine flexion, okay? Let's give it a go. Thank you, sir. Now the sun's out. You guys are out there now, you need sunscreen on. Yeah, you're not just looking at OA. How we doing? How they looking on that side over there? Thumbs up? Any questions on anything? Questions? Questions? All right. You guys almost done there? Look good. Yeah, so the question came up, well, this is a muscle test. And if they're weak with that, could you give them this exercise to go home with? Absolutely. Right? And if you decided you wanted to train them in the clinic, there's no reason that you can't add manual resistance. In fact, I think that, when we start talking about manual muscle testing, that is a great way to train if they're weak, right? And it's organic weak, it's true weakness, right? Those test positions are wonderful ways to train your patients, right? So when you learn these techniques and these manual muscle tests, these are ways you can continue to treat, and it's a little bit different for the neck, right? I just mentioned that when we assess the hamstrings and the quadriceps, those are exercises that you guys are doing at the gym already, right? And so we're going to assess, right, in a manner that we may also train them too. And so these neck movements, these upper cervical spine movements are important, right? They're important movements. Cervical flexion, right? So the motion that you guys measured, the prime movers for that are going to be the longus colli and the sternocleidomastoid, okay? Longus colli and sternocleidomastoid. For cervical flexion, we're going to have the patient in supine, okay? In supine, right? We're going to have the chin tucked, and we're going to ask the patient to lift the head off the table, right, toward the chest as far as they can go. Because we're looking for full range. And so here we're looking for motion between 35 and 45 degrees of flexion. But we're going to take up that upper cervical spine. So we're asking them to tuck the chin. Then we're going to ask them to bring that head straight up toward the chest as far as they can go. The resistance in this case is going to be placed at the mandible, right? So at the chin. Grades 3 through 5 are going to be like that. If they can move through full range for a grade 3, you progress on to grade 4s and 5s. And this is the thing. So if they don't have full range, but they have any movement at all in that particular position, right? Our next concern would be, what's a grade 1 and a grade 2 for cervical flexion, right? And we've talked about this before, that now we start looking to see is there partial range. In this particular case for cervical flexion, we're actually looking at rotational type movements, because rotational type movements are going to look at the SCM. Okay, so in this particular case, if they can't lift their head off the table, the next thing to do would be to have them check rotation, or for you to check rotation. So we're going to have the patient roll their head from side to side, ask them to do that. And for my right SCM, what does my right SCM do? My right sternocleidomastoid produces left-sided rotation, right, and right-sided side bending, okay? And so we're looking at left rotation, that's going to kick in my right SCM. So we're going to palpate over the sternocleidomastoid as we have the patient moving. If there's no movement at all, right, we're looking for palpable muscle activity for a grade 1. Okay, so grade 3 through 5 again is going to be supine. Can I have somebody come up who doesn't mind being assessed for this? Anybody at all? All right. Any neck problems? Tight. A little tightness. Just go ahead and sit up for me. Let me see your neck, just your cervical flexion for me. Any pain sitting here at all? Let me just have you bring your chin down toward your chest as far as you can go. Good. Any pain with that? Okay, again, if they have trunk weakness, you should probably stabilize them, right? Because for this particular test, we want to make sure that the shoulders are going to stay on the table. So go ahead and lie back for me. Okay, so for this particular test, have your shoulders on the table, okay? And I'm going to have you tuck your chin and go ahead and lift your head straight up toward your chest as far as you can go. Good, and come on back down. He's pushing his chin out there a little bit, but keep that chin tucked the entire time and go ahead and lift your head straight. Perfect, that was a lot better. Good, come on back down. Grade 3, chin tucked, bring your head straight up, chest as far as you can go. Good, and this is just some tactile cueing here, that's all that is. I'm just keeping a hand here because I don't want to see those shoulders start to move. Right, we're not testing rectus abdominis for this. One more time, tuck that chin and bring that head straight up for me as far as you can go. Good, so there's a grade 3, okay? Grade 4, I'm going to apply resistance, 2 fingers, not a lot, 2 fingers at the chin. We're going to do the exact same motion again. I'm going to have you tuck your chin. This time we're going to have you lift your head and I'm going to apply resistance, okay? And I want you going through that full range again, okay? Tuck the chin and come on up for me as far as you can go. Good, so there's my grade 4, okay? Grade 5, same thing again, but when he gets to the end, we're going to apply that slow count of 5. Make sure your shoulders are stable. Tuck your chin. Bring your head all the way up as far as you can go. Perfect. 1 1,000, 2 1,000, 3 1,000, 4 1,000, 5. There's my grade 5. If he couldn't lift his head off the table, I'm now going to assess rotation. Remember, sternocleidomastoid attaches from the mastoid right down to the sternum and the clavicle here. So I'm right over these areas here. So if I have him turn toward the right, all the way as far as you can go, good. See it right there. Turn toward the left, right? Sternocleidomastoid kicks in there. Okay, so any movement at all with respect to rotation would be a 2. And I'm going to palpate over those muscles again. So go ahead and turn toward your right. Right, and I'm palpating for SCM there. Go ahead and turn toward your left. And I'm palpating for SCM there. Okay, you guys should be able to palpate that muscle. A grade 1 would be no movement, but palpable muscle activity. Okay, questions on that? Oh. Remember sanitizing before, sanitizing after, or wear gloves. That looked pretty good there. Let me see that one more time. Tuck that chin, come all the way up. That looks great. Look really good. That looks good too. Not bad, not bad. Not bad. Good. That was your resistance? Did she give you resistance there? We need some resistance. Was there resistance there? A little more. She should be working. Yeah, there we go. Plus her shoulders came up a little bit too. Good, good. Remember, resistance at the mandible. 2 fingers. You got a nice SCM. See that? Beautiful. Beautiful. SCM, let's see it. Oh, yeah, man. Look at that. Nice, huh? Yeah, yeah. Right there. You guys see it?
Yeah.
Right there. Coming up. You guys doing okay back here?
Yeah, give me the,
All right, man. You guys got your SCMs? Rotate toward me. Look at that. Couldn't get better than that. Look at that. Perfect. That's like textbook. Correct. Can't lift their head. Spinal cord patient. Do we have any SCMs at all? That's important. That's important. SCM is one of these muscles that has innervation from some of the cranial nerves too. So this could be a brain injury that could potentially cause weakness here too. Raise that table up, man, so you're not stressing your back like that. You got to do this for like the next 40 some years. I heard you guys are gonna have to work till 70 now to collect your Social Security. 70. That's 45 years. You guys got to grind. 45 years you guys are gonna have to work. They want to raise Social Security at age 70. Means they got like 25 more years to go. Longer than that. That's craziness. I'd probably stand on the side. So put this hand here. I like the height of the table too. Yeah, there you go. Right over the chin. She can probably go further though. Can you go further? There you go. Make sure she goes through full range. No, because if she can't go through full range with resistance, then she's probably only a 3. Because we're not doing minuses, plus minuses. You follow me? So if she can't do full range, right, with resistance, then she can't be a 4. So we're going to grade her as a 3. Right? Keep those shoulders down. Come on down. That looks good. Tuck the chin. Come on all the way up. Good. That's it right there. There's a 3. Now apply some resistance. Let's see. I know she can do it. There you go. That's a 4. Because if they're not a 4, they're a 3 by definition.
Good thing you didn't say anything silly in there.
What? Am I still on? I am?
Hot mic.
Oh my goodness. We're almost done though.
Yeah.
2 more. Take off. You gotta go. Take off.
Yeah, I will. I'm gonna go.
Yeah. We doing okay over there?
Yeah, just got open house cheese.
I haven't even put my thing in, but I can do either. I can do either or both.
Yeah, that's fine. No, we just leave them now. People are doing self-guided tours at 10:15 and 12:15. But then she wants the groups.
They're getting this. Guys are starting to get it. Beautiful sun. Beautiful day. A little rain earlier. Guys, any questions on any of this? Questions on this? Remember, if they can move, right, tuck their chin and bring their head all the way up, go through full range, that's a 3. If they can't complete the movement with the resistance you're providing, you can't give them a 4. They're back down to a 3 because we're not doing pluses and minuses for these movements or these tests, okay? We're going to slip into the shoulder in just a couple weeks. So for the next 2 weeks, do not go right on Main Street. You can go right on mainstream with Dr. Bogolski and Dr. Boggs take over, because I know she wants to do everything online. No, she does not. So be very cautious, right? Be very cautious. We want you guys in class. This is important stuff. All right. So, sternocleidomastoid is an important muscle. It's an important muscle, and we're going to assess it. Right? We can do cervical flexion with rotation. Okay, so in this particular case, we're going to have the patient rotate, right, toward one direction and then flex their cervical spine in that rotated position. We can apply resistance to that, right? If I rotate toward the left, I'm evaluating the right sternocleidomastoid and vice versa. Okay. If I can't lift the head off the table, then we're going to go ahead and do the grade 1s and 2s. I flipped it, I'm sorry, it's on this page. Again, we're looking for partial range the same way we did before with rotation and supine. Start the patient in neutral. Can you roll your head to either side, right? Any motion at all puts them at a 2. And again, we're going to palpate for a 1, okay? And so for this particular test, can I have someone come up? Anybody? You want to come up? And you got a good SCM too. I don't know your first name though. Jayla. I didn't have you in 312 or any pre-professional phase classes, did I? This is the first time I'm really meeting Jayla. How are things going for the first couple weeks in the program? Not too bad? Good. Go ahead and lie on your back. Jayla might have maybe the best SCM I've ever seen. No joke. It was impressive. Except I got to raise the table up a little bit. And so to do the test again, right, we're concerned about weakness in the sternocleidomastoid. And so for this particular test, I'm going to ask Jayla to turn toward me, okay? And you can see her SCM, okay? Sternocleidomastoid comes right out, did the movement, right? It rotated her to the right. The one thing I want to use caution with is that sometimes folks have a little bit of a concern because when they start to rotate toward the right, if they're a little bit limited, you could see some side bending, right? We want to make sure these folks stay neutral in the frontal plane, and we're just looking at rotation, okay? So I'm going to have Jayla rotate toward the right, sternocleidomastoid is there, and now I'm going to ask her to bring her left ear up toward her chest. So she's going to flex up for me like that, full range. And we're talking about 45 to 55 degrees of flexion as being normal range, right? But we're looking at Jayla's range here in this particular movement, right? That's full range right there. Go ahead and put your head back toward the center. So the one thing I want to mention is that when we start rotating patients and keeping them there for a second or two, I think it's best if you're on the side that they're rotating toward, because you want to take a look at their eyes. One of the tests we'll teach is just static positioning and rotation to assess vertebrobasilar insufficiency. So if the vertebral arteries are no longer patent and potentially occluded, or something else is going on there, if we rotate them, there's a chance that they could bring on some of those dizziness symptoms or those other symptoms that we talked about with respect to double vision, difficulty swallowing, speaking, etc. So if you have a patient rotate, stay toward end range, I'd say stand on the side they're rotating toward, okay? And so in this particular case, again, I'm gonna have Jayla turn toward me, keep a look at their eyes, right? Rotate toward me and go ahead and lift your head up again toward your chest as far as you can go, maintaining that rotated. Perfect, there's my grade 3. Come back down, grade 4. My resistance is gonna go just above the ear on the temporal bone. Okay, so we're gonna do that again this time. I'm gonna provide some resistance for you. So come on up, keep going, keep going, keep going, keep going, keep going. There's my grade 4, right? Relax, and you can coach them, right? Because I want her to complete full range with resistance for a 4. And what's a 5 gonna be? Full range with resistance through the range, and then she can maintain that endpoint for 5 seconds. So keep that head turned toward me, you're doing okay. Hold there, 2, 3, 4, 5, and relax. There's my grade 5. Okay, for the left SCM. If she couldn't lift her head off the table, I'm going to position her back in neutral. I'm going to ask her, can you rotate your head to the right? If she can, 2. Any movement. Can you rotate your head to the left? 2. And again, if I don't see any movement, I can palpate. I can palpate the SCMs. Any contractile activity at all, it's a 1. All right? Questions on any of that? Thank you so much. Let's give that a go. After this, we got one more, and then you guys are done. Thank you, Dr. Case. Yeah. Temporal bone, just above the ear. Yeah, just above the ear. You got energy for one more? Are you guys done after this, or do you have anything more happening? Done today. That's not bad. 3:30 on a Wednesday? Not bad. That's a nice schedule. Okay. So the last one we're going to do is going to be cervical rotation. Cervical rotation to test this. We don't have pictures, but we're going to position the patient in supine. And if I'm looking at left rotation, I'm going to position the patient in full right rotation to start, right? Full right rotation to start. If they can get to that posture, right, there are 3. So they can rotate their head through full range without resistance. That makes them a 3. When we start to apply resistance, we're going to apply resistance, same area we just did, just above the ear, but this time we're going to look at a rotary type resistive force. Okay. So somebody want to come up for me? And then we'll talk about grade 1s and 2s, which are a little bit off for this one. People always lose points on this one for practicals. Grade 1s and 2s. Somebody want to come up? All right. Thank you for volunteering. Hopefully we'll have TAs in here. Okay, and so my first thing any problems with your neck at all, first off? Okay, good. Real world, no problems. Okay. Let me just have you turn your head to this side as far as you can go. Good. Turn your head to the other side as far as you can go. Grade 3. All right, turn your head again. Right, and she's staying right in the transverse plane, which is really cool. Go to the other side. Right, you sometimes may see patients when they start to rotate, if they start losing the ability to rotate, you may see some frontal plane motion, little lateral flexion. Want to avoid that. So this is just rotation. So to assess left-sided rotation, I'm going to have her rotate her head toward the right all the way through. Again, I like to stand on the side facing the patient, right? So I can see her eyes, because you want to do that, because occasionally you get a patient where they rotate their head off to the side and they start to lose blood flow. So we want to know that. So I like to just stabilize the shoulder here, just a hand here, just for a tactile cue. And now I'm going to ask her to go ahead and rotate her head toward the left. So turn your head toward the left until you get to the point where your nose is pointed straight up toward the ceiling. Okay? Let's have you just try that first off, just that movement. That movement right there. Okay? And so now I'm going to apply some resistance to that. So go ahead and turn your nose up. Keep going, keep going, keep going, keep going, all the way through. And I'm resisting that rotational type force. Bring it all the way back toward here. This time we're going to do resistance through the movement. And I'm going to have you hold it for a slow count of 5 at the end. Okay, so come on up for me. Keep going, keep going, keep going. Good. Hold right there. 2, 3, 4, 5. Okay, that's left-sided rotation. I would do the exact same thing for the opposite side. Okay, if she was not a 3, meaning she can't rotate, right? She has no movement at all. Then we're going to position the patient in sitting. Okay, the book talks about positioning the patient in a tall back chair. Right? We don't have that, right? My understanding is for us to move a piece of furniture in here, we got to kick one of you guys out. I'm not crazy about those chairs because to provide the level of support that we need. So I'm just going to have her sit up nice and tall. Okay, we just want to make sure the lumbar spine is going to be supported in a good posture. That's what we're trying to get at. Thoracic spine as well. If you're ever in a high back chair, she'll be supported. Again, if we're thinking about patients who are at a grade 2 for this, these are likely folks who are going to be wheelchair dependent, right? And we're looking to see, can they rotate at all? And so in this particular case, go ahead and rotate toward the right. Any movement in this sitting posture is a 2. Rotate toward this side. Good. And if there was no movement, I'm going to palpate the SCMs again. Rotate toward the right. Good. She's trying. Rotate toward the left. And I can feel that right SCM starting to kick in there. Okay. So any palpable muscle activity will be a 1. Right? Any movement in sitting will be a 2. So if they can't move, right, they can't rotate in supine for rotation, we sit them up for that. Okay. Any questions at all on that? Yes. Yeah, you can, like I said, these chairs aren't the best, right? They're just not the best. If you lean into that chair, you're leaning back, and that's really not what we want. We want the lumbar spine. So I'd say for the time being, just do it on the table. Get them in a good posture. For the practicals, we'll always have a high-low table. a stool, and a high back chair, right? So for the practicals, you'll always have access to that. You will in a clinic too. Maybe not the high-low table, but definitely a table of some sort. Stool and a high back chair. You'll always have that. Questions? All right, let's give that a go. And when you guys are done with that, you're done for the day. Thank you, sir. Yes. Grade 1 would be in sitting. So you're dealing with a patient who's likely wheelchair dependent. Their head's going to be supported, and I'm asking them, can you rotate your neck to the right at all? And they're trying, and they can't move, but I can palpate muscle activity. So they're trying, right? They're trying hard. I can just palpate muscle activity, right? You guys, and the patients you guys are going to treat, they're all going to be 3 and above. You're not going to see patients like that in orthopedic settings. You follow me? Unless you're seeing them for some other reason. So palpable muscle activity gets them a 1, but they can't rotate at all. High level spinal cord injury. No rotation. Some movement in sitting for this. That's the only crazy thing with this. Well, I'm not sure what you were doing there. Well, wait a second, man. This is an egg. Right? We hit each other and we do resistance, treat each other with respect. It's an egg, like you handle an egg. Soft and delicate. You should be on this side, because what if she strokes out when she turns her head and maintains it toward the right with all that direction? So hand here, turn toward me, and the rotation is like this, right? Your resistance is like that. Yeah. And nice and easy. Nice soft pillow hands.
Is that good? Like that amount?
Yeah, that was good. That was good. I don't want to see a 5-finger sandwich on someone's head, man. Yeah, you get a patient who's taking like a blood thinner, Coumadin, or heparin. You guys grab onto the head, man. They're going to come back with a 5-finger sandwich the next day. They're going to bruise up. Mobilizing a shoulder. I got 5-finger sandwiches around the shoulder. That's not good. Any questions on this at all? Yes, sir. Yeah. Yeah, fracture could do it, but the whole point is that when we test for vertebral injury, we just have the patient go down range rotation. We just have them hang out for 20 seconds. And so while you may not get around to doing that, patient may have a complaint of dizziness or something like that. It's rare, but I'd say you just want to come toward the side, because if they rotate toward the side and they do start to occlude, they're going to pass out. So that's why if their eyes start to flutter when they're in that rotational position, it's always a good safety measure just to be on that side. Yeah, so you can see it, right? But you'll know. You're going to ask, do you have any dizziness, right? Or any lightheadedness at all? And they're going to tell you no. So the chance of happening is low. But I still think for the resistance for this, you turn toward me, I provide the best resistance, right, with my body this way, versus on that side, him pushing into me, right? So I feel like it's best this way. And the book says that, stand facing toward the patient. So, yeah, we'll talk more about vertebral-based learned sufficiency too. So to clean up, once you guys are done, wipe the tables down real well, debris check on the floor, wipe the chairs down, push everything back underneath, and make sure you guys wash your hands really well. My only comment would be make sure that he gets the rotation and range would be from here to the point where that nose is straight up toward the ceiling.
So when did you have this?
Yeah, so he turns that way. I would resist with that hand here.
Okay.
Right? Yep. And so he's going to rotate. Just make sure he gets his nose pointed all up toward the ceiling, so that's on range.
Okay.
That's unrange. Just make sure he's sitting up nice and tall here. So get that lumbar lordosis. There you go. Guys, okay? Question.
And you have the like blood pressure, like I already had like low blood pressure, so
Mhm.
it kind of just resisting a little bit crazy. Is that like,
No, that can happen. That can happen. Plus, your head's turned off to the side too. So if you have low blood pressure, we've been a lot of change in positions, things like that. Are you okay right now? You feel okay? All right. Yeah. Yeah. So real world, if you know stuff like that, you let your partners know. But you may not want to be in that position for long periods of time. That's perfectly fair.
it was like normal, but then I just kept feeling like more resistance and
No.
I just got
No, you got to let folks know about that because that's real world. And you have to be your own best advocate. Okay? Fair enough? All righty. But that stuff can happen though. That's why I said you want to always stand on the side facing the patient so you can see their face. So the three were,
I don't know what I got wrong, to be honest.
yeah, you got the one wrong that dealt with, let me make sure I got this off here. The one you got wrong was, you got three